to the cheek. That one goes to the cheek, cause you don't even know you're in place yet. Now, if you wanna start off and you want to go ahead and clamp this right away, you can clamp it right away. It doesn't matter when you clamp it.
Is it okay to clamp it before you start inserting it?
You can. You
That
can.
sounds good.
Temporarily here, but then you need to remember now you need to grab your piston and your syringe. You wanna have this on the patient, just stick this on the patient for when you're doing your return demonstration, that way I know that if he vomits, I have something to catch it in. About 30 to 40 cc's of fluid for placement. You'll need to take the clamp off if you clamped it prior to.
So you don't aspirate before you do that?
I never aspirate first, I usually do an air bolus first.
Okay.
Even when I'm checking placement on my patients every morning, and when you do your 12-hour shifts in the hospital, you need to check for placement. I don't push anything in. You can aspirate to see if anything green's coming back, but I usually put my stethoscope on here, and then I do a bolus. Okay, I'm in. Remember, I need to clamp it because there's gastric contents coming out. So now I know that it's in place. What do we do next?
You gonna get the close permanently?
Well, what we're gonna do is we're gonna use his benzoin, tincture of benzoin.
You want me to open this?
Yes, please. You've actually went pretty good. And they said after you actually place the NG tube, that you can either measure the distance. Here, go ahead, can you put a little bit on his nose?
Where?
Usually just like a little bit on the top. Usually when I'm with my patients, I just kind of paint the tip of their nose. And then you want to go ahead and grab your tape. Both are just like that.
It has to dry
Or
or?
the whole nose, whatever.
If they're in the ICU, and they're going to be in the ICU for a couple of weeks, they usually get sweaty, they perspire. So wait a couple minutes, and then probably a little bit longer than that. Then you place this on the bridge of the nose. Wrap around one side. And then wrap around the opposite side. Okay, and then it's in place. Now what I usually do with the tape, you don't want it like kinked up like this. You want it pretty much like this. I usually just tape here. We really don't use safety pins in the hospital, but since they have a safety pin here, if I were to use one, I guess they say you can actually like knot around this, do like a slip knot, and then tape it to the gown. So if you're gonna do that, just make sure that you're pointing it downward. Or if you want to just tape it and then just not twist the rubber band around, that's fine. And just tape it so it goes down here. Okay, so what else do you need to do? Are we done yet?
Yes, or auscultate?
Oh, it did that.
We also
You did it, oh, okay.
Is the patient
So,
comfortable?
You know, the patient will be sticking out like this, like rigid like this.
Yeah, it may be sticking out just like that. That's why I want that benzoin to stick. You want to really let it dry good. It's supposed to be in the middle. What else do we need to do?
Side roll back up.
Side roll back up and bed down.
And do they remain in like a semi-full or
30
a
degrees.
30 degree?
30 degrees.
Does he have a time frame for us to come back and check on the patient with the tube?
You check placement. There's a couple of ways
Supposed to
you
look
can
at
check
this.
placement. You can pull back gastric secretions.
So
In your
it's supposed to-
PowerPoint, I gave the different pHs of respiratory secretions, gastric, and something else. You can look at that.
We're not supposed to hook it up?
Sorry.
Oh, I'm
Yeah.
probably the same
Suction is
question.
part of it, then we just connect it to
Yeah,
this
we're
tube
gonna
and set
get that in a
whatever
second.
level.
So you can either, I do the air bolus, bolus to check for placement. Most hospitals, they want a chest x-ray. So whatever hospital you're working for, you wanna find out what the hospital protocol is. Most of the time, they want a chest x-ray. So now you wanna attach it to suction. So you just come over here.
So you get a chest X-ray before you put it into suction?
We're missing something,
Little
connector,
connector.
and go ahead and show me where this gets connected.
I'm gonna remove this.
Okay, and then we can turn this on to intermittent. This one's really not gonna work because I showed you there's a crack on it, but some of the other ones will work. Normally what I do, I put it like this so that it's not kinda tugging when the patient moves around, so it's kind of out of the way. Okay, any questions?
As part of the testing, do we need to put that to a certain pressure?
No, just connect it to low intermittent suction. When the doctor goes ahead and places, gives you an order to place an NG tube, he's gonna say, most of the time, attached to low intermittent suction. He's not gonna say 35, 40 of low, but usually your low is the green to the, yellow area. Your high suctioning would be when you're, maybe suctioning a patient respiratory that you need high suction.
Sure.
You use kind of common sense. At the beginning of your at the end of your shift, you put a piece of tape on here, and you put the time and the date. I had 200 cc's out of this NG tube, so Paul, my credit is 200 out, it's output. So then, when you leave your shift, you'd have 300, so now we're up to 500, and you take a credit of 300, you just deduct my 200. You see what I'm saying? Now, sometimes if you come and evaluate your patient and then several hours later you look, gosh, there's nothing coming out of there. You know, he has a small bowel obstruction. I should have more gastric secretions. Patient may complain of an upset stomach, may complain of some fullness, may complain of some nausea. You want to check your placement of your tube. First thing I do, I want to check my placement. A lot of times it's just there is an obstruction, or their gastric juices are very thick and it's like stuck inside the gut. So normally I always just go through my process, always have a piston in your room, piston and normal saline to go ahead and flush. I take this off, I place this, I put my stethoscope on. Yes, it's placed. Okay, do you know what? I want to irrigate it. Take some normal saline out, pull up normal saline.
How much?
30,
30,
40, 30, 40, and I just go here. And then what I do is I put here, and I turn here, and I pop this baby to high. I want to empty out whatever's being stuck in there. And you hear, I'm like, oh yeah, there it is. Yeah, I knew it was in there. So, it's just common sense. If you're not getting secretions and this is connected and it's empty, there's something wrong. It's either not placed properly, or it's just clotted. That's when you need to irrigate. Suppose we have to go ahead and discontinue, because that's kind of one of your competencies, is disconnecting the NG tube. So how do you think you would do that?
Turn off the suction.
Turn off your suction.
Clamp
I
it.
turn off all this, get this out of my way. Take off my tape here, explain to the patient, towel. And they say what you should do is you should put this kind of like in a towel when you're pulling it out so they don't see the gastric juices. And you say, okay, Mr.
Close
Smith,
your eyes.
you know what? You wanted this tube out. Guess what? Now it's finally coming out. No, don't worry. It's a lot easier coming out than it is going in. So what you're going to do is you're going to take a deep breath. All right, Mr. Smith, grab my towel here. Once continuous motion, it's out.
And
It's a lot easier than
nothing
going
comes
in.
flying out of the end.
Oh yeah, well, just be careful. So
Close your
that's
eyes.
taking it out.
Yeah, we're like, we'll just tell them to close their eyes. When you auscultate, you're just listening for normal bowel sounds? Or what
When
do you,
you're auscultating,
to
you're
make sure the
listening
placement,
for
like
Yeah.
a
make
whoosh,
sure that it's in the stomach.
just a whoosh, okay.
Yeah, you'll hear it. If you don't hear it, or you hear it up here, it's probably not in place correctly.
Okay.
You need to hear that push.